I think you guys are in one of the most exciting places to be thinking about some of this work and doing this kind of work. I was living in India for almost 10 years and just recently moved back to the US about a few months ago for personal reasons. And I'm already missing India. It's actually snowing here today, so that's one thing that I miss about Bangalore is the weather. But more seriously, the kind of combination of having the skills and resources of a world-renowned university or world-renowned research organization with the access to kind of a very diverse population that we're trying to impact. If it's diversity of income levels, diversity of language, diversity of skills and culture and so on, was really a treat. And I think the best place in the world to have an impact with technology and with design. So I'm envious of you all still sitting there in Mumbai. I thought what we could do today is just talk through, I know Anirudh encouraged some of my personal story, kind of my interest in this space and different ways of getting involved, can touch on a few projects. Just to make sure I'm up to date, were readings assigned, Anirudh? Did you share both of those papers I had sent? Or?
Yes. We shared the papers with the students. Yeah.
Okay, great. So that's not required reading, but we'll touch on those projects if people have questions. So please interrupt with questions, and I'll try to pause because I know it's hard to interrupt remotely, and we can take conversation and questions that way. So just to dive right in, I titled this talk "Frugal Technologies." My personal background is actually in kind of high technology. I did my undergrad and PhD in kind of core areas of computer science, looking at programming languages and computer architecture and things like that. And I really enjoyed kind of the intellectual depth and challenges of that field and kind of the scholarship and inventiveness and so on. But over time, I guess you could say, was haunted by a question, which was this very simple question, which is whether technology, and you could substitute design or really any other field, really improve the quality of life for, let's say, the poorest billion people on the planet. And this was a challenging question for me to wrestle with because I think in some other fields, this might be an easier question to answer. If you work on vaccine technology or agricultural technology or sanitation technology, things like this, you can directly see the impact of your work often. I feel like technologists are often building tools. They're doing things that are a few steps removed, often from the very end user. And at least when I was a student, it was very difficult to find concrete examples where you had an innovation in the lab that then you disseminated into the hands of users and really saw kind of a fundamental impact on daily life. And so that was the question that kind of drove me when I graduated to look for international opportunities where I could get closer to some of the global social challenges that are faced by billions of people around the world. And I found this amazing group in Bangalore at Microsoft Research there called the Technology for Emerging Markets Group. And what was really special about that group is they took a user-centered design approach to the work that they did. So we had in our group people that were designers. This is Indrani Mehdi. She also happens to be my wife. Was a PhD student in IIT Bombay and with design, working with Anirudh and others. And she would spend weeks or months living in or visiting rural communities, trying to understand daily life, daily opportunities and constraints around technology, and look for ways that we could potentially have an impact. Because most of us weren't born and raised in those challenging situations. We need to actually be very empirical and go and actually study and observe and understand what the opportunity could be to have an impact. And so we bring that opportunity, those understanding back to the lab. We discuss, debrief, eventually kind of prototype, ideate, see if there's kind of modest but measurable ways where technology could have some impact in that space. And then we, as quickly as we can, take those ideas back to the field. So go back with very low fidelity prototypes, get feedback from users. Of course, most of the time our ideas would fail. I think that's actually a real strength of being so close to the field environment, is that you can quickly iterate all of these ideas and see, on Monday you have an idea, you test it with 2 users on Monday afternoon, it's a terrible idea. You come back Tuesday with a better idea, you test it on Tuesday afternoon. By the end of the week, we could have done several design iterations just with people that were accessible to us. And that kind of iteration is very difficult to do, sitting in Boston, sitting remotely. And so again, it's really a strength and opportunity of being so close to those users. And one real treat of working in this space is that we got to explore a real range of kind of challenges in global development, spanning all kinds of different application domains. So we did work in health and education, governance, and all these other areas. And I think, when you come as either a technologist or as a designer, you get to see actually issues that cut across all these different domains. So it's really a treat not to just be constrained to a single vertical, like a doctor might be, or or an educator might be, but to look at the things that are common across these. So we would find common constraints. We would find constraints of literacy, constraints of connectivity, income, and education, common methods that you use to do this work, to evaluate the work, and common platforms sometimes where we would actually have tools and techniques we would bring that would apply across many domains, and that would almost become a consultant for people in different domains, how they could use technology or design to amplify their work. So I thought what we might do today is just touch on a sample of this work. I could take questions and address other areas, but I thought first I'd focus on one of our health projects. It's not one that you were able to read about yet. We're still publishing this work, but that's one I'm kind of most excited about right now. And also touch on some platforms that we built for voice forums that I think you might have been previewed in advance of the class. So that can kind of be the plan for the rest of our time. I thought I'd also pause here to say I looked at the lineup you have for the class, and it's fabulous. Anu did an amazing job of attracting world-class speakers, and in fact you'll hear others from this group as well. So I think I saw Ed Kutrel was my manager for several years is speaking. Kentaro Toyama, it's excellent you have on the program. He's the person that attracted me to India actually to do a lot of this work. I think Jackie O'Neill I saw in there as well, my colleague in India. So I think you'll get to learn a lot about research in our group, and this will just be a sample of things to come. So that's kind of the high-level plan. Let me pause here before I talk too long. Any questions about what I've said so far? The journey of getting into this space, the infrastructure and organizations that do this work. Can you still hear me? Am I audible?
Yes. We're all here.
Excellent. Excellent. Any question? Can someone ask a question so far?
Okay. Yeah. Maybe the questions will come in this evening.
Okay, we'll dive in. Just want to make sure we've got the strong connectivity there. Great, so I thought I'd highlight one of our projects in health. And, for me, this has actually been a fabulous learning experience because it's, in a way, one of the least technical projects from the standpoint of computer science, but the most challenging and interdisciplinary when you think about design and other domains. And so, actually, my office, if you walk in these days, was just a mess of building materials stacked from the floor to the ceiling. People would walk in and ask, are you running a pharmacy? Are you running a stationery shop? Or have you become a designer after being trained as a computer scientist? So I'd really welcome your ideas and input on this project. So this project is focusing on global public health, and particularly the domain of tuberculosis, which by any measure is one of the biggest grand challenges in global public health. If you look over the past 200 years, tuberculosis or TB has killed by far more than any other infectious disease and still claims more than 1 million lives every year. And what's especially tragic about this is that TB is a completely curable disease. It's just a bacterial infection. You get it by coughing from one person to another. And in fact, there are very effective antibiotics that are freely available across most countries in the world, including India. The catch is, to make a full recovery from TB, you have to take these drugs every day for a full 6-month treatment period. And if you fall off the course of that regimen, you often don't recover and in fact can develop drug resistance, which is a much more potent and difficult to treat condition, and also contagious to healthy people around the world. And so TB is really a big threat, not only for low resource countries, but also for all of global public health. And if you look, you might think there's this very simple problem. Why don't you just take your medication? It turns out it's a deep, complex sociological problem. When you get into medication taking behavior, you touch on education. How do you convince someone with a second-grade education that your symptoms have disappeared in the first few weeks, but now you have to keep taking toxic drugs for several months to completely sterilize the germs from your system. That's a challenging conversation that requires a lot of personal counseling. There's stigma around the disease. There's loss of work opportunity. You need a relationship with your care provider that's very strong, and often that system breaks down. So there's been a lot of research on how to help tuberculosis patients complete their full course of treatment. What countries like India have done is adopt a system called DOTS, or Directly Observed Therapy, which is a kind of very heavy-hitting, human-powered intervention to improve adherence to TB medication, where patients actually come to a treatment center at least 40 times over the course of treatment, so someone can physically watch them swallow the medication. And that obviously guarantees that those doses are taken and has benefits for promoting interpersonal counseling. But the flip side is there's now a big barrier for patients as well. They need to come, take off time from work or from home responsibilities, travel long distances to a center, stand in line, have the stigma of TB and so on, pay for that transportation. And so what people have realized is that DOTS can also represent a barrier in itself for completing the full course of treatment. And so, with the rise of mobile phones and other technologies, there's increasingly been a very vibrant conversation in the global public health community as to whether we can improve on DOTS, strengthen and improve on DOTS using appropriate technologies to see if we can have something that guarantees drugs are taken while still preserving a personal relationship with patients and also letting them proceed more independently, especially when they're having a positive response to their medication, when they're doing a good job with their drugs. So this is something that caught the attention actually of policymakers in India, and there was a program actually called the Grand Challenges in TB Control a few years ago. That was funded by the Gates Foundation and USAID and a local organization called IKP. And this is, I thought I would just mention more broadly, these kinds of Grand Challenges programs are a great way to get involved in exciting new ventures and to take your ideas into the field and to scale. In fact, this same program is now in its fifth or sixth iteration. The most recent one was looking for innovative solutions to traffic monitoring, specifically in Bangalore, but sometimes they're doing in other locations as well. And it comes not only with a little bit of funding to seed your idea and to help evaluate it, but also the critical thing is that they bring government stakeholders on board before the competition. So basically, the government commits to help facilitate, deploy, and find users and so on for the highest ranked proposals. And so we took advantage of that. There were, I think, 150 proposals around TB, and we were one of those top proposals. And that helped us get an idea into the government machinery, and now it's actually being standardized across multiple states in India, as I'll say. So I'd really encourage you as students to look out for these Grand Challenges programs. You can find them just by searching on the web. The Gates Foundation also has their own thing called Grand Challenges Explorations, where they focus on different topics, several times per year. And in fact, with just a very short application, with just 2 pages often of describing your idea in 2 pages, they have sometimes $100,000 of funding you can use over 18 months for the most innovative ideas. So I think this is a really exciting thing to look at as students, and even class projects and senior theses and that kind of a thing. I would almost look at this as a way of structuring potentially some of that work that you do. So I think this is a really exciting way to get involved. Okay, so what did we invent as part of this program? Well, what we did is something we called 99 dots. So the idea is it's as good as dots, or 99% as good as traditional dots, but it has a lot of other benefits for patients and providers. And it's a frugal innovation, so it's a very low-cost innovation that preserves kind of the higher touch methods that came before. And the way that our approach works is that we take a blister pack of TB medication, and we wrap it in a custom paper envelope, which is sealed shut by the care provider. So this is a tamper-evident envelope that is always in place before the drugs get into the hands of patients. And what's special about this envelope is that on the back side, when patients dispense drugs, they punch through perforated flaps and every day reveal an unpredictable hidden phone number. And they take an ordinary mobile phone, just a feature phone or dumb phone. It doesn't need to be a smartphone. They place a toll-free call to this number, and the computer answers the phone, says thank you, and hangs up. And from that simple interaction, the combination of the caller ID, which is registered with patients at the beginning of treatment, and the sequence of unpredictable numbers that they call over time, we can have very high confidence that these drugs are dispensed and in their hand. And then other research has shown that as soon as you track drugs into the hand is very likely taken. It would take an adversarial patient to throw away the drugs and just fake adherence to the program. And so this is the simple idea, kind of a combination of physical packaging with an electronic backend that's running in the telephony system in the cloud to help patients easily self-report kind of verified medication dispersal and intake. Any questions on the simple idea? I'm going to talk more about how we respond to this information. But this was a really fun design exercise. I mean, I learned more than I ever thought I could know about envelopes and adhesives and assembly lines. And the Pan India Packaging Expo was a really exciting conference for me. So any questions on the solution?
I have a technical question.
Please, yes.
So the question is, in some countries, like in Sri Lanka and some countries, calling on toll-free number is a technical problem. So how do you get a toll-free number done?
Yeah, thanks for that question. So it turns out toll-free numbers are surprisingly complicated. They're set up in a different way than other numbers, and that they require an agreement between the telecom operators to all respect a given toll-free number. We actually had quite some challenges in ensuring that our numbers were accessible from everywhere in the country. These numbers you can call just like an ordinary phone number. There's also something called a global toll-free number, which sometimes you need special settings on your phone to enable dialing. I don't think we've looked specifically at Sri Lanka. It's possible, some countries in the world have different support for toll-free numbers. What we do in countries that don't have easy toll-free numbers is we just provide a normal toll number, and then we use a missed call instead of answering the phone and playing an audio acknowledgement. We actually found in India the missed call is a separate problem. I know you see a lot of missed call services online, missed call for voting, missed call for responding to advertisements and so on. Turns out there are a lot of providers in different states, telecom companies, that actually block missed calls to a given number because they're not making any revenue off of that missed call. And so we found when we actually track every missed call which is made, which many other advertisers haven't actually done, we saw a lot of patients that actually were unable to complete that call. So I think, in countries where you support it, there's a toll-free, otherwise where we're using a missed call. Other questions, please.
Why have separate numbers every time? Why can't you have a single toll-free number and every time you just have to call on that number and provide a different code? Why?
Thank you for that question. Absolutely. So actually we experimented with that in our first pilot with 20 patients. We gave half of them the same number every day and half of them a varying number over time. And our hypothesis was that if you have a different number every day, that really kind of encourages and rewards you for dispensing daily medication and calling a different number to show that you have a different drug in your hand. Our concern was that if they looked up in their address book or something, they could easily call the same number they had called on a previous day, if it was the same number every day. So it's a lesser guarantee from a design standpoint that you've dispensed new medication. We did find some of those patients in the condition with a single number that found it easier to recall a prior number, like they were outside their house, they didn't have their drugs with them, they got a reminder to take drugs, they placed a phone call and said that they would actually dispense the drugs later. So we think there's a possibility that having varying rotating numbers is important. It's something we'd like to validate more, and it could be, there's a much cheaper solution with a single number. You could put that number on a sticker on the blister pack instead of having a whole envelope. It would reduce the cost significantly in terms of the envelopes. And so we may experiment with that approach again, especially for conditions or drugs that have fewer doses of medication per blister pack. You kind of naturally could rotate numbers across blister packs instead of within a blister pack. So that might be a subject for future research. But I think a lot of the traction that we've gotten with the government and with international stakeholders has been this very, appealing guarantee that if you check the sequence of numbers they're calling, it's almost as good as watching them in person, because they wouldn't have known a new number to call unless they were dispensing from the pack. So I think that is a valuable rhetorical argument, and hopefully one we can also show empirically.
And one more question. So I can see that you have a sequence in which these medicines has to be taken. So why is this sequence necessary? Like, is it actually necessary, or like can they randomly take, and even then you can somehow authenticate that they are taking the medicine?
Yes, yes, excellent question. Thanks. So, turns out I'm actually showing you a slightly older version of our medication. In fact, our most recent order for a few million envelopes, we actually revised the pack to allow calling the numbers in any order. Because in fact, there's actually one of the most interesting design problems we've had in the project. It turns out it's very difficult to guarantee that patients dispense drugs in a given order. Diversity of patients with different literacy levels, education levels, even with counseling, it's a challenging thing. And when you think about it, there are two sides to the blister pack, so it's not always clear, what is the top left corner, the top right. Even with counseling, it's not clear for a new patient where they should start and where they should go. We do still have some indications to kind of make it easier for patients that are confused about the order they dispense. Really, the guarantee that we need is that every day when they dispense, like let's say they're taking 3 pills per day, which is the most common arrangement, if they dispense 3 times, they should encounter at least one new phone number. Otherwise, if they dispense in some random order, and we have phone numbers only under a subset of the flaps right now in order to reduce the other confusion of revealing multiple numbers per day, and then what number should you call. So we're trying to help them reveal about 1 phone number per day, and that's easier if you can predict at least the approximate order they would dispense in. If they're going row-wise or column-wise, it makes it easier to guarantee that. But in our latest design, we actually have a very different kind of graphic where it's a single layout of numbers for all possible dosages, and some patients may reveal more than 1 number on certain days. This is actually something, if there are visual designers in the group who are intrigued by this problem, I'd be more than happy to send over our latest artwork and see if you can improve on this. This is not by any means our training or our forte, and it's an opportunity to have a potential impact there.
I have one more question.
Please, yes, great question.
So by virtue of the person calling the number, was there a school of thought that he's also giving consent to the data collection?
Yes, consent is an interesting question. This is actually a very interesting question overlapping research and practice. When you get into the government system, the public health system, they're collecting a lot of data on patients without explicit consent. It's part of the treatment protocol that they collect certain details on the patient and use that to improve your treatment. And hospitals and government programs everywhere around the world, they're always trying new innovative things that they think will improve the standard of care for their patients. So up until now, 99 dots has mostly been used in this programmatic setting, where it's part of the routine standard of care for patients. And so there have not been additional measures of consent that have been gathered compared to just the standard process that came before. We of course did have informed consent for our first experimental trial when we had 20 patients that tried it for the first time. We had no idea if it would be good or bad. That went through a formal IRB process and informed consent for patients. But right now we actually have about 75,000 patients actually that have used this, as I'll highlight on a future slide. And that's just part of the routine standard of care. So I think it's a very interesting space, especially as innovators and designers, where when something is an experiment, it's critical to have consent, and probably we should get consent more often, even in the routine standard of care. But the way it often works in reality is that if it's part of a routine program, which you're just trying to do the best thing by patients, those intermediary partner organizations are making the decision on behalf of the patient, and so they're not gathering additional consent.
I have one question.
Great.
The question is, what if for some reason I could not connect to the caller ID that is given, and I could not make a call, but I did take my medicine as a patient, and then for the next, so I thought like maybe for the next call I'll make a call. So there are two parts of the question. What if I dropped the medicine or something happened to it because
people have variable access to mobile phones. Sorry, I missed the last part.
So, for some reason, I could not call the particular, for example, the second number I could not call because it could happen that I dropped the medicine, or it could happen that I could not connect I was traveling, or there was no number available. So, will my third medicine will be considered a second medicine, or will that be considered a third medicine, third dosage or something like that?
Right, right. So there are all kinds of legitimate reasons that patients might not be able to call on a given day. They lost their mobile signal. They were using their spouse's phone who had to travel away from their house. So often there's medication that's ingested which is not self-reported, and that basically comes back via manual conversations. So I'll tell you next about kind of how we use this information, and we send missed dose alerts to assigned health workers for the patients, and if they see a series of missed doses, they try to follow up with the patient, and if in their estimation that if they do a house visit and they have strong evidence that the drugs are still being taken as per kind of the directly observed therapy protocol, they can actually go into our dashboard and mark what we call a manual dose, which isn't the same as a self-reported dose. It shows a little bit differently, but it shows at least that there was a follow-up event where someone tried to understand and make sure that the patient was taking those drugs. So at the highest level, this might not be a solution for 100% of patients. I mean, we find, people talk a lot about the mobile penetration, in India and other countries, and there are more SIM cards than people, and all those things are true. But when you get into really rural areas, it's still the case that access to phones is not ubiquitous. It's not something you can assume for every individual. It may be something you can assume on a community basis, that if a household has to access a phone, they can find a way to do that, or there's shared phones and intermittent phones and intermittent connectivity. We found a lot of scenarios where a fraction of patients are not in a position to make daily calls, and so they need a different standard of care. They could potentially have more frequent observation or some other more automated and expensive devices that others are developing. To the question of dropping a pill on the floor, of course that could also happen, and we see those irregularities in the sequence called, and we're forgiving to a certain degree with respect to that sequence. Great questions. Any last ones here, or should we move on? Good. I'll say a few more things, and we'll take questions again. So that's the information that we get. Of course, if there's a health impact from the system, it's how you act on the information. So we have a whole set of escalating reminders and alerts when patients do not self-report dosage. First, it goes to the patient, although of course most patients can't read SMS, and actually we're scaling it back our SMS reminders. Where it's required, we can send SMS alerts to patients, potentially in countries with higher literacy. That may not be the highest intervention in low literate parts of India. Providers also can have either SMS alerts, or now they can use a mobile application to also check on their patients. And supervisors can see transparently adherence in a center. This is an example of a patient in Bangalore where they were going well for kind of the first few weeks of treatment, then they started missing doses. This was escalated automatically through our algorithm to someone that followed up with the patient, found there was a educational misunderstanding. They were feeling better, thought they could discontinue drugs. In fact, it was even more important to continue that medication. And so this is a case where that counseling and automatic escalation brought this patient back on treatment. There are similar cases even the other way around, where patients start feeling worse and they attribute that to the medication. And in fact, they were feeling worse because they weren't taking the medication, and it was a symptom of TB. And so that early counseling is really important to provide. We have similar impact on whole centers. So this is showing the aggregate adherence in a hospital and the average self-reported adherence via 99 dots. As you can see, it was declining month by month, either due to lesser adherence or lesser usage of 99 dots. That triggered a retraining session in that hospital, and you immediately see the metrics start to tick up. So it's the kind of data that previously wasn't available to administrators. It wasn't even digitized, and even if it was, it would take weeks or months to respond to. And now we have a real-time, transparent view of all these operations in centers around the country. So because of this kind of potential that we saw through early kind of anecdotes, there's actually been pretty radical scale-up of 99 dots throughout India. So right now we have about 75,000 patients enrolled. We've printed and distributed millions of envelopes that we can plaster whole parts of cities with the envelopes that we've printed. And actually we have a trajectory to potentially enroll a few lakh patients in the next year. So it's been standardized, in fact, including in Maharashtra, the new standard of care is to use 99 dots for TB patients, and we're in the process of rolling that out to every clinic in the state. Also in other states, there are 4 other states where they're using this for every new patient. And in fact, in Mumbai actually was the first place to launch. So about a year ago, starting 1 year ago, every TB patient in Mumbai has been using 99 dots. Now this obviously goes far beyond kind of the mandate or scale of a research project. And so we actually spun out about a year and a half ago a startup company. It's a social enterprise. It's for profit, but it's funded by grants. So it's kind of an expenditure responsibility endeavor where some of my colleagues left Microsoft. I'm involved as an ongoing advisor. And now we have a dozen people who are working full time in Bangalore to help scale this out. And so that's been really fun and exciting, kind of that process of really making things real and robust and user-friendly. And we're always, we're very focused on the operations, but we bring a background and sensibilities of research and innovation and design to try to make the system as effective as possible. Everwell is also hiring for those of you after you graduate. Please feel free to reach out to me directly if you're interested in this kind of work. We're growing really fast. We have lots of ongoing research that I could mention. I'm going to actually skip that slide and talk instead about some lessons learned along the way. Any questions on last few slides?
Fine. Very impressive.
Good. Oh, sorry, was there a question?
No, I was just saying it was very impressive.
Oh, good. Thank you. Yes, what I was going to tell you now is that's not the first time we tried to do something like this. We're still trying to understand even the success of 99 dots, and I'm not sure that we could do it again. There was kind of perfect alignment of a lot of different stakeholders and incentives, the way the government was looking to change the program and kind of the ideas we were bringing to the table. And in fact, kind of the lessons we learned, I think, is often the most interesting part of projects. Whenever you meet someone, by the way, researchers and entrepreneurs and so on, don't talk about their successes. That's kind of the uncommon case. Try to ask them about their failures and what they learned from the things that went wrong, because that's often where really the learnings came from. So I thought I would share a few of those failures with you. The first time I actually worked in TB in India was actually out of grad school, where we took a much more kind of physical approach. We actually designed a pillbox for TB medications that isolated every dose and tracked when it was dispensed. When we took this to the field, it didn't work at all. There were all kinds of problems. There were challenges of production, distribution, maintenance of a special purpose device, which, by the way, I think is very challenging in low-income areas. I'm not even sure if there's a precedent of, let's say, 75,000 users of a new physical or special purpose electronic device designed specifically for a low-income environment. I would welcome counterexamples. Please email me or speak up. I think that's a very challenging thing to design for, because you need such a network of support. It's not just about producing them, it's about distributing them and supporting them. And really the successful cases that have come are things like mobile phones, where they were actually designed for a different context, kind of the high-income context, and then became cheaper and cheaper and more robust, and there's a whole ecosystem to support them. So this didn't really work for us. There are people now that are looking again at pillboxes, and maybe they can build a better support network within the government, but I think they're still going to wrestle with some of those same challenges. The other thing we found is that in the field, it was very challenging to deploy this in a resource-poor area. We were working in rural Bihar that lacked the right support infrastructure, and so one thing that we've learned and rediscovered and relearned again and again and again is probably best articulated by Kentaro, who I think is talking to you in a couple days or maybe next week, which that just when you bring technology, that by itself very rarely creates positive social change. And we've learned that lesson the hard way again and again, and I'll leave it for him to flesh out all the thinking behind that. But for now, I'll just give an advertisement for his lecture. I think it's some of the most incisive and useful insights and advice that I've ever seen for how to approach doing positive social work as a technologist, as a designer. The other thing that we learned, I'm going to skip ahead, is about evaluating programs. So with one of our other previous systems for TB, we kind of made the mistake of convincing ourselves it was a good thing, even though it actually wasn't working as well as we thought. And this is the basis for one of the papers that were shared in advance of the class. Actually, what was not in that paper was kind of where that paper came from. It was from one of our projects in TB, where we had a system we thought was good, and we sent out someone in our program. So one of the designers of the system went out into the field and interviewed patients and providers and asked them, do you like this thing that's obviously he was connected with. It was something that he was trying to promote in the field. And he got a lot of good responses, all kinds of anecdotes, all kinds of testimonials on how this is the greatest system ever. And I was naturally a little skeptical of kind of the very positive response that he got. And so just, kind of in parallel, we sent out someone else to do the same interviews. Someone disconnected from the program, someone that the patients and providers had never seen. And that person came back with very different data. It turned out that people were much more willing to share critical responses and negative experiences with someone that they were sure or that they believed had no connection at all to that intervention. And so that experience was really transformative for me because it just shows how easy it is to fool yourself into thinking that you've built a good thing. I think we all love the things that we create. We want to celebrate them and look at all the positive sides. And we love the things our friends create also most of the time, friends and colleagues. But when you're going out into the real world, it's really important to elicit that critical feedback, and which is often very difficult for people to provide. And so one just really fun study that we did, which was the subject of that paper, was to see if we could quantify that bias, quantify that challenge in collecting accurate data, evaluating a new design in the field. And so this is something we called participant response bias. And if you looked at the paper, it was a really fun one. The lead author, Nikki Dell, is fabulous. She's now a faculty member at Cornell. And sorry, is she also talking here? Maybe not.
Oh,
I forgot.
No, she's not.
Okay, fine. Maybe another time. So she's great to talk to. So she actually came and along with some colleagues, they did more than 400 interviews on the street, and it was interesting experimental design. What they did is they went and they hailed auto drivers to start with as a very accessible user group, and they asked the auto driver a simple question. Here are two mobile phones, two smartphones, and I want to show you a music video on each phone, and I want to tell you which one you think looks better. And the only other cue that they gave is that, oh, by the way, we're working on improving the media player on this phone over here in my left hand. And so that was the prompt given to drivers, which phone looks better, and I'm working on improving this one. And the catch was, there was a deceptive experiment. In reality, they were identical. The two videos were identical. The phones were identical. An unbiased observer would have no reason to prefer one or the other. They were actually, identical, interchangeable phones. But what we found is just with that simple cue that, auto driver thinks that one phone might be better, or that the experimenter, the interviewer, has some vested interest in one of the outcomes, you see an enormous bias that comes back. When they express a preference for either phone, it's a factor of 5, the margin by which they prefer the phone that was somehow connected to the interviewer. So that's something that was identical, and you measure something to be 5 times better in a way. And that was with a foreign interviewer. It turns out the bias reduces a little bit if you have a local interviewer, but it's still there. It's still multiple factors. Even if you go to graduate students, you might say, oh, auto drivers, they're easy to convince one way or the other. No, we go to ISC PhD students, ask them the same question. Still there's a bias, more than a factor of 2. And they just intellectualize it more. It's like, oh, yeah, this phone has more, better chroma aberration, or, you have some advanced tracking going on here that looks really good. So it's a really kind of fundamental inbuilt human tendency to want to be a good participant in a study, and if that means providing, positive feedback for what the experimenter built, that's what people are just innately programmed to do. And in fact, as a follow-up, we even degraded the quality of one of the phones. So we took that experimenter phone, we cut the frame rates, we cut the resolution, we made it a terrible, awful video, really. Like someone else coming in and watching it is like, this is garbage. Why would you even show this to someone? Still, a statistically significant fraction of respondents expressed a preference for that video. So the end learning is you can walk in with an artifact which is obviously worse. It's clearly worse than what was there before, and with commonly used HCI methods, you can get a result which says that it's better. And so you need to just be extremely careful. I mean, since this kind of study and experiment, I have just been a mess of paranoia whenever it comes to evaluating any of my own things. I mean, we need to be really careful to not ask the questions ourselves, to extract and interpolate from other kinds of data, to triangulate responses, and that's where the real knowledge comes from. And so I think people that are very rigorous in their methods can help to reduce or avoid this bias. It helps to have a local person do it. It helps to have someone unconnected from the research. It helps to have, layers of indirection, so maybe ask what other people think of the thing, or observe them over a long period of time. But kind of that direct feedback is really challenging, especially where there's a power dynamic between the interviewer and the respondent. So any questions on this? I know some people might have looked at the paper. I'd welcome any questions you might have. Yeah.
So are there any frameworks which we can use to overcome participant response bias?
I think that is a fascinating question and a really important question that has not been adequately answered. I think it's a place that people could innovate and could have studies and so on. I think.
In that case, what should be the parameter that we should consider?
Yeah, so I think, the gold standard scenario is just avoid any self-reported data. Look at other indicators of benefit. I mean, if you're trying to impact people's health, you measure their health. You measure how long they live, their bacteria in their body, do they recover? It's hard to lie with the biology in your cells. Or measure their income, measure their farming productivity. Self-reported goodness of any intervention is really, subject to such biases. I think there are other ways, of doing different kinds of qualitative interviews. Like, really strong ethnographers will go and establish a deep personal rapport with a participant. I mean, they don't just go and ask questions like we did on the street. They'll go into someone's house. They'll have 3 cups of tea. They'll tell them, why they're doing a graduate program instead of getting married. All these things. They'll share something about themselves. They'll have a really deep connection with someone, and only then do you seek critical feedback from a participant. And we had those people, even in 99 Dots. We had a trained ethnographer who spent an hour with each of those initial 20 participants and got some of them to admit, that, I didn't actually have the drug in my hand when I made that phone call. And that's something you would never get with a quick question. So to get critical feedback, you have to really seek it out. You have to, go and they're telling you other stuff that they wouldn't tell anybody else. And maybe that's your indicator of when you're getting closer.
I had a question.
Yes.
So, I very faintly remember it from my psych classes. It was one of the Rosenthal effects, experimental bias effect. So,
Yes.
How does it differ from what you all found?
Yeah, so this finding is not new. So this has been well characterized and studied in the context of psychology. It's often called demand characteristics, or you can see, interviewer bias or other kinds of bias. If you look online, there's actually a taxonomy of different kinds of bias you can find on Wikipedia, which is fascinating actually to understand all the sources of bias in interviews and so on. What was new about our study was that it was situated around a technology intervention. So I haven't seen anyone else measure, especially in the context of interaction design, when we're using just textbook HCI methods of doing focus groups and trying to do iterative design where participants are providing feedback, just how much scrutiny we need to bring to that feedback which is volunteered from participants. Because at the same time, you find a lot of papers in our community and conferences, the academic conferences like CHI and so on, where these are the methods that are used, at least in the prototyping stage, and sometimes even in the ultimate evaluation. And that's something that we need to reduce our reliance upon as HCI researchers, is looking at other metrics for when things are good.
Okay, thank you.
So this bias won't be considered if you're doing user study. Like this will be only after we're evaluating a product. So while we're actually going and understanding what the user needs, does it affect them as well? I mean, usually because when a product is in hand and you don't want to say bad about it. But what if the product is not there and you want to contribute to the needs? So could there be a bias on the user asking questions, the provider asking questions?
Yeah, that's a great question. So I think that same bias will be there. I mean, what's in common between those two scenarios is that people want to be a good participant. So if they, sense that we're looking for any particular response, they're very likely to try to provide that response or something like it. So I think it's equally problematic during needs assessment and understanding users and formative research as it is, if you're focusing on an artifact. It could be fun actually to characterize that. We could think about experimental designs that are like that, where you ask a question where you somehow already know the answer. I mean, you know, if you have more information about them, it'd be fun to think about experimental designs where you could actually measure that. But I think there's going to be a problem there too. Good. Any more questions on this one? Great. Well, I'm gonna skip ahead. I think we have 15 minutes left. Is that the schedule en route?
Yeah, but this is So they just dinner after this. So.
I'm sorry.
It's just dinner after this, so it's okay.
There's the dinner.
Dinner. We are only going for dinner after this, so it's okay.
Only going for dinner. Well, I can't stand between you guys and food. That would be. Well, good. So we can go a few minutes over if we need to. I thought I would skip ahead just for benefit of people who read about the other project. We won't go into as much detail, so I'm going to just give the highlights and then open it up for discussion. But another thing that I've been really excited about in my time in India is looking at how we can look at very basic voice interfaces to replicate and enrich local community. I mean, replicate other internet services and provide rich local electronic communities. So, if you look on the internet, you find a lot of useful content for folks like us, a lot of useful ways to publish and talk about and engage in different conversations. If you're a low literate farmer in a rural community, it's pretty challenging to engage with the internet right now. I mean, the signal is coming, the smartphones are coming, I think devices and connectivity will get there, but then there's an enormous gap in language and literacy. The languages of the internet are very few, it's mostly English and a few other high-income languages. The modality of the internet is predominantly text. You go and you search with text on the internet, you read search results, you read web pages in text. If your primary way of communicating is with your voice, with an oral culture in your local language, which is frequently, not a language of the internet is still pretty useless for you as a member of a rural low-income community. So I wanted to see, can we change that if we move the focus away from those textual interfaces in different languages to voice interfaces in local languages? And what we did, we actually built a system as a prototype exploration that we call CGNet Swara. And this is a voice portal for reporting rural stories in people's local language. And so what they do is they pick up a phone, they call a phone number, they get a simple interactive voice response menu where they can press 1 to record a message, press 2 to listen to messages others have recorded, and there are a few other options to look at kind of recent impacts of the messages and so on. Those recordings go to a moderation team who reviews for basic kind of tone, completeness, some fact-checking to the extent that it's possible. Then they publish that story on the internet, on cgnetswara.org is our website, and they also release it back on the phone line. So you don't need a traditional internet connection to access the content. You can call in and listen to what other people in your community have recorded. And often, once public stories are released, there are also a team of activists, it turns out, that monitor the stories, and where there's follow-up action needed, like if there's a community problem, they go and they take action on behalf of those people reporting the stories. And so, there's a system where it becomes possible for the first time for people not only to access information, but also publish information just using their voice. And I think that's still a very kind of rare and important capability that not a lot of systems have embraced, is, just with a phone call in my local language speaking, can I record something that's, broadcast to the whole world, that connects with people locally in my community and also as a voice around the world for the same way we would publish a blog or a, photo sharing, video sharing on the internet. There's a way that just with a basic phone in my local language, I could have a way of publishing. This has been a project we've been doing over a long time, past 8 years now since we launched. We've gotten about 1 million total phone calls, small by the standards of a product, but pretty decent for a research project, and about 12,000 posts that have been published, curated and published on the channel. What we didn't expect is that, we thought people might record, local news, songs, cultural content. Very quickly, the content switched to being about local grievances. So it turns out, if you give people a platform to speak about what's important to them in rural central India, where we were working, in Chhattisgarh, Madhya Pradesh, and so on, what's most important is failures of public service delivery, problems that have not been solved with traditional reporting mechanisms, and that's what people want to talk about. And so there's an early shift of the platform into one that was about, conversations and narratives and so on, into one that was largely about problems, identifying problems, and getting those problems fixed. I think what's most exciting for us is that problems did get fixed with the system. So just having this capability of, reporting to other people in your local language, lots of problems got fixed. So, there was one in the paper we highlighted where there was a medical emergency. There was cholera in a village. Actually, the medical officer had fled. They weren't sure where to turn. They immediately recorded an emotional message on CGNet Swara. They got routed to the right official, and then hospitals came and intervened and fixed that scenario. There's not a one-time thing. I think the paper that was sent was kind of characterizing the impact. We've seen it actually, now there's been more than 650 similar impact stories. Hand pumps that are broken get reported and fixed. Outages of electricity, land rights, education, all this kind of stuff is stuff people really care about and they talk about, and then activists are able to follow up. There have also been some interesting kind of statistical impacts. This is one of my favorite charts. This is actually showing the number of official deaths due to malaria in the state of Chhattisgarh with their official figures. As you can see, early 2000s, it was kind of impossibly low. People didn't really believe these numbers. It was kind of an underreported problem. And this is when our service started. And in the first year of CGNet Swara, we saw more authentic reports of malaria than over the several prior years acknowledged in the official documents, and very difficult to ignore reports. I mean, health workers that are afflicted by malaria, very emotional, authentic reports of malaria deaths. And we can't prove any impact here, but there are others that have attributed a change in the conversation to that system. So you saw in the years thereafter, there was kind of a change in the culture of reporting malaria in the state. And you have to be careful how you interpret this. Our system did not cause malaria. You always have to be careful when you're interpreting statistics. But there's a case where providing a straight reporting platform could potentially help problems get resolved. We wrote several papers on this platform. The one in the middle, I think, was shared with you, looking at different kinds of impact. We also recently compared it to a state-run grievance redressal system, which was also a very good initiative, and kind of found ways that a citizen-led initiative could still have advantages even compared to a well-resourced, much larger official initiative. There's lots of research we're doing now on how to scale up this platform, but I thought I'd pause here, maybe for those of you who read the paper or are intrigued by just the last few slides. Any questions about this project?
So I have two questions. First is, since this was the study, CGNet was more prominently active in Chhattisgarh. That is Naxalite affected area. I mean,
Yeah.
there's a constant fight between government and the
Yeah,
people there.
yeah.
So there, if you report something which could go against them for some sort of knowledge, some sort of information, so because the phone number has been exposed, because the identity has been exposed, so are we taking care of anonymity of the person, the user who is reporting?
Yeah, so that's a great question. So it turns out, a lot of these platforms are often envisioned for reaching kind of the poorest of the poor. Like it's, completely inclusive. There's no technical constraint that would prevent anyone from directly participating. I think what we find in practice, both for CGNet Swara and also for a number of other related systems, is that the usage often ends up being intermediated. So if a, very, very poor farmer has a grievance, they don't necessarily pick up the phone and bravely report it with their own voice, at least not at the very beginning. They seek out an existing activist in the community who has a history of, trying to militate for social change on behalf of that community. And most often it's those intermediaries who are at least doing the initial reports for people. And actually, they feel quite comfortable with, attaching their name and phone number. I think there is the option, we could say, to keep the report anonymous, though I don't think that's ever been really taken advantage of. It's kind of the protocol now that you introduce yourself and actually include your contact information as part of the report, and that's kind of become part of the culture of the platform. I think, you mentioned about the political tensions and so on. I think. The actual collaborators that we have on this project, we as Microsoft is just providing the technical platform, the capability of recording calls and playing them back and seeing what kind of online communities you can create. Of course, there's a very rich and delicate, social agenda around this as well. And actually, our collaborators view this as a peacekeeping, experiment where, maybe if some of the problems that are there in rural areas can be voiced even from, those same populations, and government can be very responsive to those concerns, that could help reduce even some of those tensions, that, you could restore hope that the system as it is can actually work and so on. So they view it as being a very positive thing for, potentially curbing and preventing violence. I don't think we've measured that or proven that by any measure, but that's certainly high on the cognizance of the founders to be very sensitive to those potential risks and escalations.
The second one was I've seen all the images that we saw just now. They required someone who was actually holding the phone. So I'm assuming people are still reluctant to use new technology. So there would be some member in the family or in the community who would be recording on behalf of those people and sending them to the moderators. So how different is it from a reporter reporting on the field? Live on the field, because eventually it still gives power to an individual, but a lot of people are not affected eventually because the limitation of usage of basic technology is there.
Yep, absolutely. I think it's a really important critique is that just because you create a platform, or just because we create a platform that everyone hypothetically could use, doesn't mean that those people automatically use it. I mean, it always is a deeply social challenge to have social inclusion, to increase the feeling and reality of agency, personal agency, and participation, and initiative, interest, and ability to kind of fight for certain rights and so on. And so, those things are not changed at all by those dynamics are not changed at all by introduction of this platform. I think if it's different from other journalism platforms is that it is open to, activists. There are a lot of activists. You could say it's kind of connecting rural activists with urban activists. It's taking people that are very, have high initiative, high energy, very good intention, some amount of skill, working in rural areas, and giving them a platform where they can easily collect information from people and highlight that for other urban audiences to get involved, to sign petitions, to put pressure on officials and that kind of a thing. But it's absolutely true that just creating the platform by itself doesn't mean that everyone uses it. And so that's a parallel activity that we have to undertake, and we do. We being, again, our partner organization, the CGNet NGO, though they have an enormous investment of energy and resources of actually going from one village to the next. They put on a traditional puppetry and dance program that explains, forget the technology, it explains the scenario. I mean, why it's important to be vocal about certain issues, like who's listening, what are the dynamics, what is possible for those communities to, how they could affect change and how they could participate in the process. And so it's really important to engage with those potential users and non-users on their own terms in their own community. That's a long, intense conversation. It certainly doesn't happen just by creating a phone number. In fact, if there's anything to take away from this, and also the prior project, is that those impacts that I highlighted had very little to do with the technology. I mean, it's the capability and intention of the moderator team, the activists that are following up, the people that are collecting the stories. That's really where the change is coming from.
Sir, I have a question. So as you said that you started with the idea of connecting rural people to the network through this voice-based interface, but later on this whole system basically shifted to grievance addressing portal kind of thing. So did you design this grievance addressing system beforehand, or after this thing happened you noticed it and then incorporated some changes to take care of these problems?
Yeah, so it was an emergent behavior. I think at the beginning it was an experiment to create more communication, to create an open dialogue. Can we have a more democratic media, something which is accessible to anyone who is, skilled and enough to use the system, as opposed to controlled by a small number of, moderators that work at, newspapers or so on, and cater to urban audiences. So basically, what was committed from the beginning from our field partners, again, was to take the system in its own direction, follow the content, follow the narratives, see what's reported, see what's valued, see what has impact. And that naturally led to a focus on grievances. I shouldn't say that grievances are the only thing. In fact, I skipped a slide here. There are people where, if you saw that in the paper as well, the biggest impact for them was the ability to sing, to share, their folk songs and the voices of their school children with the world. And so we saw a diversity of engagement, and I would say we haven't quantified it recently. Probably the majority of the posts on the platform are grievances, but it's certainly not 100%. There's a significant fraction of other content as well, which is kind of rich cultural content and other kinds of content. And so, it's continuing to evolve according to the, emergent directions. Good, so I know we're at time. I thought I might leave you with one last slide, which is kind of, high-level things I've learned in these projects. The first one is, again, will be fleshed out again by Kentaro, but, I think in all these projects, there's a tendency for technology to want to substitute for people. What can I automate, especially now with AI, like what's the next job that will be eliminated? What can a computer do better than a human? I think really the much more exciting and impactful opportunity is how we can amplify human capabilities, and that's something you've seen in all of these projects. None of these were completely automated systems. They were technologies that came and require more investment from people as opposed to less. I mean, you need partial dialing manually of a 99 dots phone number. You need, manual reports and moderation and follow-up in CGNet Svara. How can we actually have computers and humans work together so they're both doing more work overall and empower people to actually be part of the equation? I think often the behavioral change that you see in projects never comes directly from a new technology either. It's all about the incentives that are either transformed or enabled by a new system. So, adding incentives of transparency, now a health worker can be recognized for the good work that they do in improving adherence of their patients. Now there's more transparency for an administrator to solve a problem and be rewarded for that. I would start actually by looking at the incentive structures, not kind of the technical or user interface structures, but like what are the incentive structures and how could a new technology modify that structure? Leverage existing devices whenever possible. All the stuff I'm using here is decades old technology, which immediately facilitates uptake and makes it very accessible. Fail fast, I mentioned in the beginning. For every success that I've highlighted, there are a dozen failures in the background. And I think that the key thing to have any chance of success is to just try an enormous number of ideas. And that means, cycling through them very quickly, with users that are on your fingertips. And I now am extremely aware of potential participant response bias as a guide for choosing what to work on and how to do it. So with that, I'll leave you for today. My email is here. Please feel welcome to write to me. And I look forward to future interactions.
Thank you very much. It was great to have you today, Bill. So thank you very much for spending so much time.
Thanks, Andrew. Thank you, Deepak. Thanks, everyone. Thanks for all your questions.
Thank you.
Great.
Okay.
Sign off.
Are there any questions?
Yeah, any last questions? I still have a few minutes.
Yeah, they're just okay. Maybe one.
So, thank you, Bill, for such a nice talk. So in case of 99 dots, was there any motivation provided for the user since they have to take drugs for a 6 months of period? If not, what do you think has worked in your case to make them to allow them to use the drugs for 6 months?
Absolutely. So that's a case coming to these incentive schemes that's really interesting. We want to motivate patients to accurately report their adherence. Right now, the biggest leverage we have for doing that is the ability for them to proceed independently. So, if they can't use 99 dots, they might be put back on a more traditional monitoring, protocol where they have to make more frequent trips to a center. So that's kind of the reward that they have, is more independence. Other people have experimented with financial incentives. Should we give them a mobile top-up if they call, consistently? We've always been wary to go down that path. That other people have had experiences where if you introduce adverse incentives, or too high of incentives, you end up with adverse, weird behavior. So actually in South Africa, there was a highly publicized case where the government was just doing a cash transfer to benefit TB patients. You're diagnosed with TB. Eventually you qualify for some cash reward, or cash compensation. And there were tragic, heartbreaking cases of people seeking out tuberculosis for the benefit of the money. And so you have to be really careful for things like that. We don't want to distort the accuracy of data that we're getting just because we're incentivizing it a certain way. So we're still thinking about that a lot, and I'd welcome new ideas there.
Okay. Any other questions? Okay. So finally, thank you very much again, and
Fabulous. Thank you, Anirudh.
see you sometime later. Bye.
Yep. Enjoy the class. Yep. Take care.
Thanks a lot. It's been great,
Bye.
actually.